Hello, my name is Olubisi Faoye, and today I am presenting my mixed method research proposal. The working title that I settled on is a mixed method examination of how health literacy, self-efficacy, and social support relate to healthcare utilization among Medicare beneficiaries. I will go through the background and problem, the theoretical and conceptual framework, the mixed method design, and how I plan to collect, analyze, and integrate the quantitative and qualitative strands into this study. I will start with the context and the problem, then move into the purpose and research questions. I will then explain the conceptual framework guiding the study and highlight key points from recent literature that justify the study. The bulk of the presentation will cover methodology, how I plan to conduct the quantitative and the qualitative phases, and how I will integrate them. I will close with the issue of rigor, ethics, anticipated contributions, and a brief timeline. So to frame the study, I start with the Medicare context. Medicare covers over 65 million people in the United States, and the portion enrolled in Medicare Advantage continues to grow every year. Older adults in particular, they use more health services and manage more chronic conditions than younger adults, which makes healthcare navigation especially consequential for this group. Recent work from Centers for Medicare and Medicaid Services, CMS, and Kaiser Family Foundation, as well as MedPAC, highlight wide variation in utilization, such as the use of emergency department, hospitalizations, and telehealth by plan type and by beneficiary characteristics. At the same time, we'll still see consistent disparities in access and utilization based on income, race, and ethnicity, geography, and cognitive status. My study is mostly interested in how personal resources like health literacy, self efficacy, and social support might help explain some of these utilization patterns. The problem is not only high utilization or high cost, it's misaligned utilization. Beneficiaries who delay necessary care or rely on emergency departments for conditions that could be managed in primary care. Studies of Medicare beneficiaries show that those with low health insurance literacy are more likely to report unmet care needs. There is also growing evidence that social isolation and limited social support are linked with increased emergency visits and hospitalization among this population. This pattern raised concerns about equity and quality. If literacy, confidence, and support act as gatekeepers to effective use of Medicare benefits, then certain groups may systematically receive less appropriate care, even though they are insured. Formally, the problem this study addresses is the misalignment between Medicare coverage and actual effective use of healthcare services. We do know that older adults and people with disabilities are generally at a high risk for chronic conditions and complex health needs, but their utilization patterns often reflect delays, foregone care, or sometimes avoidable acute care. While prior research has examined some aspects such as health insurance literacy, self management, and social or community engagement, very few studies look simultaneously at health literacy, self efficacy, and social support, and then connect those quantitative patterns with in depth qualitative accounts from beneficiaries themselves. This is the gap that motivates this particular study. The purpose of my study is to use an explanatory sequential mix method design to connect quantitative patterns with qualitative narratives. First, I want to model the relationships between health literacy, self-efficacy, perceived health competence, social support, and utilization outcomes like primary care visits, emergency department use, and delayed care. Second, I want to hear from beneficiaries themselves about how these resources actually show up in their day-to-day navigation of Medicare and healthcare. And finally, I want to integrate both strands to produce an explanation that is statistically grounded but also rooted in the lived experience of people using the system. The ultimate goal is to generate knowledge that can inform design of supports, educational interventions, and policy that reduce avoidable barriers for Medicare beneficiaries. The study is anchored in Anderson's behavior model of health services use. Anderson's model classifies determinants of healthcare utilization into predisposing, enabling, and need factors. In my study, predisposing factors include demographic characteristics like age, gender, race or ethnicity, and education. Need factors include chronic conditions, self-rated health, and the number of chronic conditions that the person has. The focal construct of health literacy, self-efficacy, perceived health competence, and social support are treated as enabling resources that either facilitate or hinder the movement from need to actual use of service. Utilization outcomes such as primary care visit, specialist visit, emergency department use, and delayed or foregone care are modeled as health behaviors using the Anderson framework. Recent reviews show that Anderson remains a robust and flexible framework for contemporary utilization questions, including in older adults and marginalized groups, which justify its use for this study. This line narrows the focus from the overarching Anderson model to the specific construct. Health literacy here is not only about reading ability, it's about being able to interpret planned materials, understand instructions, and then act on them, which is especially important when dealing with multiple chronic conditions and complex benefits. Self-efficacy and perceived health competence are drawn from Bandura's social cognitive theory. These constructs shape how likely a person is to initiate and persist in behaviors like scheduling visits, following up on test results, or appealing denials. Social support is conceptualized functionally. It includes emotional, informational, and practical help. For older adults, having someone to drive them, explain letters, or sit with them during visit can be the difference between getting timely care and letting it go or delaying it. My guiding proposition is that beneficiaries with stronger resources in these domains will have more appropriate and timely utilization patterns, even after accounting for demographics and need. I treat these frameworks as nested under Anderson. They provide detailed definitions of the enabling resources and process measures that feed into utilization. The study is organized around three core research questions. The quantitative question asks about the statistical associations between the enabling resources, health literacy, self-efficacy, perceived competence, and social support, and the multiple indicators of access and utilization. The qualitative question asks beneficiaries to narrate how these resources show up in their real life experiences. What makes it easier or harder to schedule visits, understand coverage, or follow a care plan. The mixed method question then pulls the strands together by asking how the narratives can explain or deepen the statistical relationship. This structure aligns with the mixed method research guidelines of having at least one overarching mixed method question and single clearly articulated quantitative and qualitative questions. Recent work reveals that health literacy is both a persistent and modifiable issue for older adults. Studies show that lower health literacy is associated with poorer health outcomes, but there's only an emerging focus on interventions, including digital navigation, focused literacy for Medicare beneficiaries, especially. Lower health insurance literacy has been linked to unmet need for care and difficulty using benefits, which supports the idea that literacy is a key enabling resource. However, we still lack mixed method studies that combine population level patterns with in depth accounts of how literacy challenges actually play out in day to day navigation of Medicare. The self-efficacy literature is robust, particularly in chronic disease population. Higher self-efficacy is consistently associated with better self-management and improved functional outcomes. Recent work also shows that self-efficacy can mediate or moderate the impact of self-care abilities on disability and role limitations, emphasizing its importance as a psychological enabling resource. Social support and broader social participation have been linked to preventative care use and, at the other extreme, to increase acute care utilization when support is limited. However, there is still a lack of unified picture that combines health literacy, self-efficacy, perceived competence, and social support within a single model of utilization for Medicare beneficiary. And this is what this study aims to contribute. Here, I lay out the quantitative variables. The independent variables are the enabling resources measured with established instruments that have recent validation or psychometric work. The dependent variables come from Consumer Assessment of Healthcare Providers and System, CAHPS Health Plan Survey items, and related Medicare experience questions, capturing both objective counts of visit and self-reported access barriers. Covariates reflect predisposing and need factors in Anderson's model, demographics, social economic indicators, plan type, and health status. On this line, I'm expressing the quantitative hypothesis using correlation notation as suggested in the course document in Canvas and from our class discussion. I'm not entirely sure that if I did this particular part correctly. I define U to represent appropriate and timely healthcare utilization. In practice, this will be constructed from indicators such as higher primary care and preventative visits, fewer preventative emergency department visits, and fewer reports of delayed or foregone care. Higher values of U represent better or more appropriate utilization for each predictor, such as health literacy, self-efficacy, perceived health competence, and social support. I'm stating the same basic directional hypothesis. Under the alternative hypothesis, I expect a positive correlation between the predictor and the U. That is, as literacy, self-efficacy, competence, or support increase, appropriate utilization should also increase. So mathematically, that's written as the rho greater than 0. Under the null hypothesis, I assume there is either no relationship or a negative relationship, which is expressed as rho less than or equal to 0. This correlation form is consistent with the idea that I'm examining the relationship among variables, even though in the full analysis, I will move beyond simple correlations to multiple regression models. The rho notation allows me to state the hypothesis clearly and succinctly for each predictor. In terms of mixed method typology, this is an explanatory sequential study. I will begin with quantitative survey to model the relationships between enabling resources and utilization. Then I follow up with qualitative interviews that are strategically sampled from the survey respondents, such as those with high needs but low utilization or low literacy but high self-efficacy. Integration happens at several points. I use the quantitative results to guide qualitative sampling and interview questions, then bring the data sets together in joint displays and narratives that clearly connect the patterns and the stories. This design is particularly well suited to my goals because we have some evidence that these constructs matter, but we do not have rich explanation of how beneficiaries navigate real-world Medicare contexts with varying levels of these resources. The study focused on community-dwelling Medicare beneficiaries rather than people who live in places like nursing homes, partly for feasibility and partly because navigation challenges may play out differently in the community. Inclusion criteria are aligned with Medicare eligibility and the need to answer questions about utilization over the past 12 months. For the quantitative phase, I will recruit through community-based organization, senior centers, clinics, and potentially through outreach tied to Medicare counseling program. I will probably also send out emails to some people that I know, in terms of associates, to see if they'll be willing to participate as well. For the qualitative phase, I will use the survey data to identify contrasting cases. For example, beneficiary with low health literacy and low utilization, or those with high literacy but continued barriers, as well as those with strong social support versus those who are more isolated. This maximum variation approach will help ensure that the narrative shows different paths through the system. For the quantitative strand, I'm targeting around 250 to 300 participants, and I understand this could be very ambitious. I'm not sure I know 300 people. A standard power analysis for multiple regression with around a dozen predictors suggests that around this number or sample size is adequate to detect medium effect sizes with conventional levels of power and alpha. This is consistent with similar utilization studies using Anderson's framework in older adult populations. For the qualitative interviews, most guidance suggests that 15 to 25 interviews are sufficient to reach thematic saturation when sampling is purposeful and conceptually grounded. Because I will be sampling across multiple combinations of literacy, self-efficacy, and social support, I will have to monitor emerging themes and adjust recruitment as needed to ensure coverage of important subgroups. Here are the details about the instrument for the enabling construct. The brief health literacy screen survey will help me to identify limited health literacy in busy settings. It has been widely used with older adults and is consistent with recent scoping reviews on measurement. The promised self-efficacy for managing chronic conditions is part of a well-established measurement system with robust calibration and validation across chronic disease population. including older adults. The perceived health competence scale has a broader sense of health-related confidence that complements HAC's specific self-efficacy. Recent adaptation and validations in different adult populations support its use. For social support, I'm using the 8-item medical outcome survey short form, which has strong evidence of reliability and one-dimensionality and is less burdensome for older respondents than the full 19-item version. Together, these four instruments will allow me to capture personal and interpersonal enabling resources in a psychometrically sound yet visible way. For utilization and access, I will use items adapted from the CAPS Health Plan Survey Medicare version. CAPS provides a standardized approach to measuring patient experience, including ease of getting needed care and appointments, communication, and certain aspects of utilization. By combining CAP-style experiential questions with self-reported counts of visit and emergency department use, I can get both perception-based and behavioral indicators. Covariates reflect standard predisposing and need factors in Anderson's framework. Demographics, social economics indicators, and health status, including chronic disease burden. The structure of these items is aligned with national surveys like CAPS and the Medicare Current Beneficiary Survey, which helps with interpretation and comparisons. Quantitative data collection will be community-based and as accessible as possible. I plan to recruit through established community partners who already serve Medicare beneficiaries. This includes senior centers, clinics, and aging service organizations. Surveys will be available in online format using Google or Microsoft Forms. The consent process will emphasize confidentiality, voluntary participation, and a separate option to participate in follow-up interviews. They will be de-identified and stored securely using institutional data management guidelines with unique identifiers linking the survey and interview for those who opt in. Once the data collection is complete, I will begin with descriptive and reliability analysis to understand the sample and ensure the instrument perform adequately. I will then examine correlation among the enabling resources and initial associations with utilization measures. The main analysis will use regression models appropriate to each outcome, linear for continuous counts that are approximately normal, Poisson or negative binomial for skewed count, like emergency department visit, and logistic for binary outcomes, such as having delayed care. These models will include health literacy, self-efficacy, perceived competence, and social support as predictors with demographic and clinical covariates reflecting predisposing and need factors. I will examine standard diagnostics to ensure that the models are interpretable and that no single case unduly influences the result. This result will guide the purposeful sampling and focus of the qualitative phase. For the qualitative strand, I will conduct semi-structured interviews with a diverse subsample of survey participants. Sampling will intentionally vary across literacy, self-efficacy, and social support levels across utilization patterns. For example, those who rely heavily on emergency department services versus those who are more engaged in primary care. The interview guide will invite participants to tell specific stories, like times that they tried to make an appointment, understand the letter, or decide whether to seek care, as well as how they handle coverage denials or confusing bills. I will probe for the perceived confidence in this situation and for the roles played by the family members friends, clinicians, and any community organizations. The goal is to obtain rich, concrete examples that help us understand how the enabling resources are experienced and mobilized or not, whichever is the case in the real world. For the qualitative data, I will use reflexive thematic analysis informed by narrative approaches. Coding will begin with deductive categories tied to the Anderson model and the focal construct, but I will also remain open to unexpected themes that emerge from the data, such as digital health literacy challenges, prior negative experiences, or particular roles played by adult children. I will write analytical memos throughout to document decisions and reflection. Example codes will be used in joint display to bring the statistics to life and to illustrate how people actually navigate Medicare in the context of the resources that they have and constraints. Integration is not an afterthought in this study or design. It is central. I will connect the strands by using survey results to decide who to interview and what to ask. For example, if the quantitative results suggest that social support is particularly important for reducing emergency department use, then I might specifically seek participants who vary on support and emergency department use and ask them to talk about how others help them decide when and where to seek help. Then I will merge the strands in joint displays, placing coefficients along thematic summaries and illustrate quotes. This would allow me to see where the strands converge, where they tell complementary parts of the story, and where they diverge in interesting way. The ultimate goal is to produce a meta inference that are only possible by looking at numbers and narratives together. I want to briefly acknowledge issues of rigor, ethics, and limitations. On the quantitative side, the use of validated instruments and appropriate sample size planning will help ensure analytic rigor. On the qualitative side, careful documentation, reflexive practice, and explicit integration strategies will support credibility and coherence. Ethically, I will pay attention to consent, privacy, and needs for older adults or individuals with disability. I also recognize limitations, including the non-probability sampling approach and the reliance on self-report. This will be acknowledged and addressed in interpretation. In closing, I expect this study to contribute to theory by refining our understanding of enabling resources within Anderson model and to practice by identifying specific targets for educational interventions. For policy, the findings may inform how Medicare health plans and community organizations approach communication and support for beneficiaries who are at risk of unmet needs. My immediate next steps are to finalize the instrument, uh, obtain an RRB if possible, and then proceed with data collection, assuming this whole proposal actually gets approved as is. These are sample references that I will expand in the full reference list. All are formatted according to APA 7th edition and are recent with a focus on the last 5 years, although sometimes I find that I have to pull articles older than that. They include sources on Addison's model, Medicare and utilization patterns, health literacy, self-efficacy, social support, and CAHPS-based patient experience measures, which together support the justification, framework, and methodology of the study. It's more of my references. And thank you, Dr. Bokrice. I hope you enjoyed listening to that.